All right, so today we're going to be talking about prostate cancer screening. And the reason why it's important to talk about this topic is that it's very controversial. We're not sure if there's any benefit really towards doing prostate cancer screening or not. And the problem is a lot of men expect to have prostate cancer screening done over the age of 50. So really what we're going to talk about today is whether it should be done or whether it should not be done. And it's important because prostate cancer is the fifth leading cause of cancer death in all men. Men have a 16% lifetime risk of developing prostate cancer. So it's fairly relevant. The problem we have with prostate cancer is that men only have a 3% lifetime risk of dying. This means the majority of men who develop prostate cancer who are diagnosed will die of other causes. And the problem we have with prostate cancer is we don't know which disease is going to go on to become aggressive and fatal, and which disease is going to stay localized to the prostate, never become clinically relevant, never metastasize, never cause any harm to the patient. And we know that the majority actually stay localized and don't cause any harm, but we don't know. And once we find it, we have to treat aggressively. So that's the problem, that's the dilemma. And really the way we screen for prostate cancer is going to be with either PSA or digital rectal exam, or a combination of both. And the PSA is very inaccurate, and the reason being is that it was never intended to be used as prostate cancer screening. In fact, the PSA was actually developed to look for recurrence or progression of prostate cancer after treatment has already been initiated. In about the 1990s, they decided to use PSA as routine screening for the routine health assessment in men over 50. And the big problem we have is that PSA is very non-specific. There are a lot of things that are going to increase your PSA levels. Things like prostatitis, BPH, natural inflammation that occurs in the prostate, ejaculation, urinary retention, rectal exams, prostate biopsy. So all of these things are going to increase PSA levels. The problem we have is that because this is the only way of screening, once a PSA level is elevated, now we have to go to biopsy. And biopsy is very inaccurate with the prostate. This means that when we do a biopsy, there's a 20% false negative rate. This means the quote-unquote gold standard biopsy, we do it, we're going to miss 20% of cancers. And to reduce the likelihood of missing cancers, we have to take 12 separate samples of the prostate. So elevated PSA level means 12 biopsies of the prostate. And this comes with its own set of problems. Just because we have an increased PSA and we have a negative biopsy doesn't mean we haven't caused morbidity in the patient. Patients become anxious, they become depressed. We have erectile dysfunction, urinary incontinence, bowel problems, not only from biopsy, but from aggressive treatment, which I said we have to initiate once we have positive findings of prostate cancer. So screening can really lead to increased morbidity in patients, but we found that it doesn't actually decrease mortality. We do not save lives by screening for prostate cancer and or doing the digital rectal exam. And that's the dilemma we have here. And the PSA will actually become elevated 5 to 10 years before you have any clinical disease. So there are a lot of problems that affect prostate cancer screening, and that's what we're really going to discuss today. Should you do it? Should we not do it? Who should get it done? What do we do after we do it? So let's get into a little bit of the more specifics here. All right, so moving into the specifics here. Now, when we do PSA, we're really going to be using a cutoff of 4. And that's because we believe that when you have a PSA over 4, 30% of those patients are actually going to have cancer. If we were to raise the cutoff to 10, 50% of those patients would have cancer. The problem is raising the PSA level to 10, we found that the majority of those patients are actually going to have incurable disease. They're not going to be localized to the prostate. So although raising it to 10 increases the likelihood of this test being more specific, the patients we would be diagnosed just far too late for any type of treatment whatsoever. So removing or bringing down the value to 4 makes it less specific but more sensitive, meaning we catch more cancers. Now here's another problem with PSA. Although we have a cutoff of 4, it's still very likely to have a cancer diagnosed under the 4 cutoff. This means we can have prostate cancer with a PSA of 2, 3, 1, and it's even estimated that PSAs with a level less than 1.1 will miss 17% of cancers. So 17% of cancers are diagnosed when PSA levels are less than 1.1. This makes this level 4 cutoff very arbitrary. We could still have cancers under 4, we can have cancers over 4. It's very imprecise, and this is another problem that the PSA screening brings. Now, when we do DRE, right, digital rectal exam, we're really looking for induration, we're looking for asymmetry, and we're looking for nodules. If we feel any of these, then we go to biopsy. Same with PSA levels over 4. We have a level over 4, we go straight to biopsy. The problem with doing the digital rectal exam is that it only can feel and we can only palpate for cancers that grow peripherally. This is only 85% of cancers. So if we're doing digital rectal exam for screening, we're going to miss 15% of cancers. And the cancers we do find on digital rectal exam, for the most part, are going to be incurable. They're way too advanced to actually do anything with this. And also, by definition, stage T1 cancers are going to be non-palpable. So really, the digital rectal exam does not reduce mortality. It increases morbidity because now we're doing more biopsies, now we're doing more aggressive treatments. So this is the problem with PSA, and this is the problem with digital rectal exam. Now, moving on to the ultrasound. We should not be doing ultrasound after an elevated PSA, after a possible induration or nodule found, because it doesn't change management. And actually screening for prostate cancer with an ultrasound is going to miss 40% of cancers. So let's say we have an elevated PSA and we do an ultrasound, a rectal ultrasound. We don't see anything on ultrasound. We still have to go to biopsy. Let's say we do see something on ultrasound. We still have to go to biopsy. So why do the ultrasound in the first place? Elevated PSA, positive digital rectal exam, no point in doing ultrasound, go straight to biopsy. Now the one exception is if you're using the ultrasound to guide the biopsy, right? So we can do ultrasound guided biopsy, and that is okay. But you should not be doing ultrasound as the next step in screening or in the workup of possible prostate cancer. Now, once we do biopsy, this has its own risks. We have bleeding risk, we have infection risk. Some patients need to be hospitalized because of this infection. Many patients report having pain for many days, even up to over a week after the biopsy is done. Because remember, we're doing 12 separate biopsies. It's not just one. So the biopsy in itself has its own inherent risk. And it's really estimated that over 30% of cancers, prostate cancers, are going to be overdiagnosed. Like we said, overdiagnosis means that we diagnose prostate cancers, but these will never become clinically evident. These cancers will never metastasize, and the majority of these patients are going to die from other causes. And there was this really, really big study done where we had patients who passed away from other causes and autopsies were performed. 30 to 45% of patients who died in their 50s had prostate cancer, and they died of other causes. When we looked at the 80 age group, 80% of patients who died in their 80s had prostate cancer, but they died of other causes. Again, the screening decreased mortality, it does not. It increases morbidity. And these are some of the reasons why all these societies decided to go against universal screening. All right, so we talked about the pitfalls with prostate cancer screening, with PSA, and with digital rectal exam. Now, although it's not specific and it's not universally recommended, your patients are still going to want to be screened for prostate cancer. So, although the guidelines are against universal screening, they are for shared decision making. Meaning, at the age of 50, you start to have a conversation with your patient. You tell them about prostate cancer screening, you give them the information, you tell them the risk, you tell them how it's not specific, and if it is positive, we have to continue the workup. And if they decide to continue on with prostate screening, then we go ahead and screen. Now, if you decide to screen, like I said, we start at age 50. You should do with PSA only, and you should not do digital rectal exam because the majority of patients that are diagnosed on digital rectal exam are simply too late or clinically irrelevant, and it's going to miss 15% because we can only palpate what grows peripherally. PSA is just a better test overall if we decide to do screening in the first place. So at the age of 50, you should do screening. Now, the frequency of screening isn't universally agreed upon. Some societies say 1 year, some say 2 years, some say every 4 years, because prostate cancer is very, very slow growing. So whether it's 1, 2, or 4, that's going to be a personal decision. Now, I can tell you a lot of people, a lot of clinicians do yearly screening as part of the annual physical. If it's over 4, it's really up in the air. But if you have a PSA that's over 2.5, then you should strongly consider doing yearly screening with PSA. And you should only do prostate cancer screening in patients that have over a 10-year lifetime span ahead of them. If we don't have a lifetime expectancy over 10 years, then either way, it's not recommended to do prostate cancer screening. And we can stop PSA screening at age 70. So we do it from 50 to 70. Frequency could be every 1 year, 2 years, or 4 years. If it's over 2.5, the PSA, then we do it every year. If for whatever reason you do a digital rectal exam, you feel indurations, you feel nodules, asymmetry, then you refer to biopsy. If you have a PSA level over 7, they go straight to biopsy. If you have a PSA from 4 to 7, then at that point, you might want to repeat the PSA before sending the patient off to biopsy. And the reason is, we said a lot of things like BPH, inflammation, prostatitis, trauma, ejaculation can all raise PSA levels. So if we have a borderline PSA from 4 to 7, then you should probably repeat in about 4 weeks. Before doing PSA testing, 48 hours before, make sure the patient doesn't have intercourse, make sure there's no ejaculation, make sure there's no trauma. And something that commonly causes trauma is going to be bike riding. So make sure the patient is not riding their bike and abstain from sex 48 hours before repeat testing. If the PSA continues to be elevated, meaning over 4, then yes, they should then be referred to biopsy. Now remember, biopsy is not accurate. It's not very specific, and it misses up to 20% of prostate cancer. So although we're doing multiple samples, we can still miss a large percentage of prostate cancers. Now, whether that's relevant or not is up for debate, but some experts recommend that you repeat biopsy even after having a negative biopsy, because on repeat testing, they're found 20% of these cancers are then found. Again, that's going to be a personal judgment. That's going to be up to you. And whether they're found on repeat biopsy testing and these are significant, again, is up for debate. So that concludes today's lecture on prostate screening. The big takeaways here are, it's not universally agreed upon. There are a lot of flaws. PSA is very non-specific. Digital rectal exam will miss 15%, and for the most part are only going to diagnose those that are incurable, that are advanced. So whether you do or you do not is up to you and the patient. It should be shared. It should be a shared decision model. And we have to realize that the majority of patients who do have prostate cancer are going to die from other causes. And the majority of patients with prostate cancer will continue to have localized disease that will never cause any increased morbidity or mortality on the patient. I'll see you in the next lecture.